Okay, well, maybe in the interest of time, I'll just start by introducing our lovely, wonderful guest who has joined us here today from Northern Ontario. Welcome to our Lunch and Learn session called Equity Centered Learning Health Systems, the Case of Northern and Rural. We have Dr. Brianne Wood joining us today. And she's joining us today from Thunder Bay, Ontario. Is that right, Brianne? Yes.
That's correct.
Okay.
That's where I am.
Okay. Where she holds the position of Social Accountability and Learning Health Systems Associate Scientist at the Northern Ontario School of Medicine. Dr. Wood has a PhD in epidemiology. And through her role at NOSM, she supports primary healthcare research, quality improvement, and capacity building in Northern Ontario. She has a particular interest in equity and learning health systems in northern and rural communities. So we really thank you for joining us here today, and I'll just pass it over to you.
Thank you so much, Julia. And again, an honor and a pleasure to be here. And hello, everyone. Thrilled to be able to speak with you very briefly about something that I'm really passionate about, learning health systems, equity centered. It's very jargony, but I know that it's starting to become more familiar in our vocabulary. So yes, I'm calling in from Thunder Bay, Ontario, the traditional territory of the Fort William Anishinaabe, signatory of the Robinson Superior Treaty. Here I have a picture of Kakabeka Falls taken a couple winters ago. Well, actually it was spring, but it was after one of the most ferocious winters. And so the Niagara of the North, as we call it, was flowing quite heavily. And so this is just sort of solidifying that connection to the land and connection to our environment that is so common in northern and rural communities. And for those of you that don't know, sometimes I refer to Thunder Bay as like the Prince George of Ontario, and Prince George is the Thunder Bay of BC. I think we have similar positions in terms of the hub nature of northern communities. And so I am squeezing a lot into 25-ish minutes, but I do really want to interact. And so I encourage you, please feel free to use the chat or the Q&A function on Zoom, but also if you want to interact on your cell phones or on your laptops, whatever you may have, feel free to go to menti.com. You'll see the little bar at the top of the screen. You can also use the QR code, enter the code, and you'll see the slides as we go through, and there will be some interactive opportunities. And I've already talked about my land acknowledgement, and again, another picture of the lovely, beautiful nature that I get to live in. And so I'll give a bit of background on learning health systems, the sort of boring theory, conceptual stuff, the equity-centered part, which I think is top of mind, I'm sure, for people in the room today, in the virtual room. And then I'm going to talk about something that is usually overlooked in most of the learning health systems literature. And I actually started a talk recently just saying that I have a chip on my shoulder. And so to take that into account, and maybe some of you do as well. You know, we're often in these urban centric places and spaces that don't think about the differences that northern, rural, isolated communities face. And then where are we going from here? And so feel free, test it out. What are your interests or areas of expertise? So feel free, I'm going to open the chat, but I want to see who's in the room. If you are able to type into Menti, I'd love to know, do we have researchers? The Menti link should be at the top of the screen. Hopefully you can see it. I'll type it into the chat as well, menti.com. There we go. All right. So we do have research, clinical, policy, love it. Okay, so we have a ton of different perspectives here. And you guys are my people. This is so cool. Amazing. Public health. Yes. Something else I learned about BC. I love how much more integrated public health is into the health system than it is in Ontario. So that's great. Fantastic. Okay, I'm just going to keep plowing ahead, but thank you so much. And again, I do feel like it's my people. So this is something I've taken from Rob Reed and team's publication on the Learning Health System Action Framework. But we know, that typical language or that statistic, it takes 17 plus years to move research into clinical practice. That's our implementation science knowledge translation quick stat. So originally, research and healthcare, two distinct enterprises. And then we started talking sort of early 2000s, really about the moving knowledge to action. And where's knowledge translation and integrated knowledge translation. And actually these principles and philosophies still stand true today and are an important part of this new sort of approach or model of learning health systems. And so it's about, the push and pull from research to healthcare in integrated or knowledge translation, and then actually intersecting. So how can we embed research in the healthcare system, and how can the healthcare sort of voices and perspectives really get themselves into the research perspectives and actual processes. And of course, so learning health systems started to become more of the jargon in 2007, coming from the Institute of Healthcare Improvement, and naturally all the conceptual models followed from there. So there are tons of different frameworks out there. Some you might like more than others, and that's fine. Some may click with you. How I really like to see it, I do like this sort of 3 different learning cycles, meaning, we start with practice, like actual health and social care practice. So on the ground, point of care, patient, client, people interactions, collecting data there, moving that data into knowledge. So that really analytic space, turning that data into knowledge, and then turning that knowledge into action. So those are kind of the key pieces of a learning health system for me in terms of the machine of learning. And then of course, the outcomes, we're starting to hear and see more about the quadruple aim, the quintuple aim. And certainly here in Ontario and in other provinces, this is the Learning Health System Action Framework that some people really like to use. There are 5 different learning gears. I'll highlight them quickly. So that, again, the machine of the learning is analytics and population insights, evidence synthesis. So that's like systematic reviews and that kind of thing. Really emphasized patient, caregiver, provider, community, people co-design. So really love that emphasis on collaborative design and production. Implementation, so the actual starting to move it into action, and then evaluation and monitoring. And of course, we're seeing the quadruple aim: population health, patient people experience, health workforce experience, cost sustainability, the language around efficiency. But we're also seeing equity as its own gear, which is really, really important, again, given the political climate that we're in right now. And of course, there are fuel and accelerants, talking about different partnerships, funding, that kind of thing, as well as moderators and brakes. So, using that metaphor of an engine. And then a colleague of mine, Ibkin Abjurinde at Trillium Health Partners, we wanted to dig deeper into that. I mean, we somewhat didn't criticize the action framework, but really teased out some pieces and some tensions around how do we actually operationalize this in an equity-centered way. And so often equity-centered just becomes tokenistic, I would say. And it actually becomes hard because the idea of, well, equity means one thing actually doesn't stand. And so the idea of doing an equity-centered learning health system actually means we need to be contextualized to the system in which we're working. Again, Northern and rural probably know this. The other pieces that we talked about in this paper, in the presentation, were about balancing the timelines. Learning health systems are all about rapid learning. Like, how do we get knowledge into action more quickly? But many of you that do partnered work know that we go as fast as we need to, right? We go as fast as partners are ready and willing to go. And then the final point is that we need to practice. We're not going to be perfect all the time, but we actually need to practice these principles regularly to get better. Sorry. So I've presented a bunch of frameworks. Are there any immediate reactions? So this is a word cloud. Feel free, put in one word, put in a couple words. Let me know. Do these resonate with you? Does it resonate with the work that you're doing right now? I mean, I don't know if you can find emojis in there, but yeah, peers, awesome. Yeah. I should be entering my own words, because I can be entirely critical of it. But what I do, quality data, partnerships, yeah, absolutely. Data, yeah. Yeah. And you know what? It's really interesting. A 2020 publication on a systematic review of learning health system literature found that we really emphasize the data and tech pieces, less of a focus on the rest of it. And yet I think many of us would argue that partnerships and collaborations are what get us going. Oh, love it. Okay, someone figured out how to do an emoji. So good. Okay. Dynamic collaboration, partnership, perfect. How to measure equity. Would love to chat with you more, because these are questions that I'm asking as well. Yeah, great. Stories, fabulous. Okay. Flexibility, yes. Adaptive, right? How do we do that? And so again, quickly, before I go into my little, not really a rant, but my perspectives on Northern and rural, how do you think Northern and rural systems, learning health systems, are going to look different? I've given a couple of examples. You can be as broad and generic as learning, you know, the way that we do learning. I mean, you know, judging from some of the comments on the last slide, maybe it's data, maybe it's the way that we are so used to partnerships. So would love, and maybe you don't know, and that's okay too, because there isn't a lot of thinking in this space. Virtual, yeah. Virtual in so many ways, virtual healthcare, and feel free, I think you can probably offer as many perspectives. Rural remote voices often left out. Oh my gosh, exactly. Exactly. I'm just trying to move this so I can read. Same people. Oh, whoever said the multiple hats thing, I think you're going to like one of my slides. More burdensome, too many silos. Oh gosh, yes. Geography, doing multiple roles, tasks. Okay, yeah, this is Julia. I'm so glad. Like these are my people here. Fewer people find same. Yes, exactly. Taxing for those who are doing it. Absolutely authentic. Misunderstanding of the Northern context. Yeah. For those of you that don't know, so Thunder Bay is on the northwest shore of Lake Superior. I was just at an Ontario-wide conference last week, and there was a screenshot from a senior government official that, the screenshot of a data dashboard, and there was no Lake Superior. It was just, hey, here's Toronto and the data for that. So gosh, do I feel that. I love the cowboy emoji. Relationship continuity, absolutely. Doing more with little resources. Okay, so North tends to be underfunded, need to be creative. Okay, so yeah, I totally agree. Here is the shore of the aforementioned Lake Superior. I took it a couple of years ago. I'm actually just going to skip ahead because I just want to say these are my thoughts. And the many hats thing, yes, that is exactly how I see it too. We are generalists because we have to be. There aren't as many people, and we don't have the same resources. We can't all, like, we're specialists in a generalized way. And unfortunately, that is often undervalued, especially from people in urban centers or metropolises that have the ability to do that. And so absolutely, we see that where I am, and I feel that strongly. Agreed. You know, it's a really interesting tension. So someone commented on the silos, and we are super fragmented, sometimes geographically, like we have to be, but we also have to work together, because otherwise, you know, care won't be delivered if we don't work together, or the actual health system won't operate appropriately unless we work together. And so that nature and that expectation of collaboration is ingrained in us. And so we actually have longstanding partnerships that go far beyond, the funding opportunity du jour. Population health profiles and priorities, I mean, perhaps unspoken. We are, and I'm curious if others have this experience, in Northern Ontario, we have over 106 First Nations reserves. And so there's a higher proportion of Indigenous perspectives and also unique Indigenous nations, First Nations, Inuit Métis. And so there's like this expectation that anyone living in the North is an Indigenous expert. As well as just this sort of masking of the North as a singular entity. And so actually our heterogeneity is usually grayed or blurred. Academic institutions. So I do work for the Northern Ontario School of Medicine, social accountability, this idea that we need to be accountable to the communities and people we serve. That actually stands more true, I would say, in Northern and rural, but we are place-based. And especially when we're doing and thinking about equity-centered work, this stood out when I was working with Ibican, is that a lot of other populations don't necessarily have that tie to place and land in the same way that Northern rural. And maybe this is obvious to many of you, but it was sort of like an aha moment for me that, the equity sort of goals and perspectives that we bring are really cemented in our place and identity. And then that makes our focus and the way that we do our jobs, quality improvement, clinical health system, like actual patient care, it looks different. And our commitment to sort of creating impact is different because of that place-based nature. And so I'm coming now back to the previous slide that I skipped quickly. And so why does it matter that we actually think about Northern and rural learning health systems? Well, I included naturally an Ontario specific publication, but in 2017, an agency for the government published the Northern Ontario Health Equity Strategy, describing the disparities between the Northern Ontario population and the rest of the province. And I used to have a speech bubble here that said, 7-8 years later, all of the recommendations still stand true. So we don't get a lot of action. An Auditor General report said we don't have a dedicated healthcare strategy, and that a national report on the health workforce said we know that the workforce needs in rural, remote are greater, but the gap's actually going to increase over time. So it is actually pretty critical that we think about Northern and rural learning and honor its uniqueness. But actually the time is now that we need to start investing in it. And I'm not saying I think everyone in the room can agree we do need to invest in it, but we need to see that response from provinces and federal governments. And so realizing I have, 5-ish minutes left, I'm going to just go quickly through a couple of examples of some of the work that I've done with Northern and rural learning, but want to come back to this group. So there was actually worked with some wonderful BC folks, including your keynote speaker, Dr. Markham, about what are the outcomes for a learning health system in a Northern and rural context. And so we looked at the literature and we held an in-person meeting. And you'll see some pictures from that meeting. And what we found is that, and maybe this will resonate, that there were 7 different themes of outcomes that are really important. And this is how we measure. And so you might be familiar with the Pentagram Partnership Pentagram Plus. And so, you're seeing that in the number and nature of relationships and communication across systems. From a couple slides ago, we talked about adaptability, flexibility. We talked about holistic health. It means more than just, absence of COPD hospitalizations. And, there's an indicator of the day for us here. Governance of data, knowledge and action, using 2-eyed seeing approaches. So appreciation of the different knowledge systems. And we actually need to think about sustainability, not only health system sustainability, but larger than that. And so I'm going to skip ahead, but we had some goals about where we go, and it was really cool to bring people from Newfoundland, BC, from the territories all together. And as a result, we got this sort of, I don't know, amplification in a national level initiative, the Learning Health Hub, but it was a 1-year CIHR grant. And as many of you noted, like there's so many asks of people working in northern and rural settings that without dedicated funding, we actually can't continue this work to understand and to build northern and rural learning health systems. And so, some of this work has fallen by the wayside, unfortunately. The uniqueness of, and we actually covered this a lot. I mean, I think everyone in the room kind of knows, but here's an example that I'm intimately familiar with: not having data and measurement or evaluation capacity. So that research, that, analytic and learning capacity on the teams, in smaller communities, they just don't have it. And yet the expectations are still there from these, the health system funders. You need to provide data, you need to, do performance measurement on this. And so what we did in Northwestern Ontario is that we created a regional structure, sort of that backbone, that also focused heavily on capacity building. And so it was, the hub and spoke model, if you will, where we had sort of a centralized in the north learning system. And our job was to sort of work with teams to get their data research jobs done. So this was a success in the way that, teams felt heard and they felt able to actually tap into some of the evaluation expertise they wouldn't otherwise had. But it was really challenging. We're only a small group. And so being able to address all of the needs for a large number of teams, even though the teams themselves aren't large, it was a lot. It was a lot. And the fact that this is something I'm sure many of you live day to day is that you're being asked to do the same amount of work as someone with significantly more resources in a more urban setting are being asked to do. So, and then the uniqueness of the population. I spoke to this. Indigenous data sovereignty is huge, not really well understood, certainly by provincial bodies, and perhaps I'm speaking out of turn for Ontario, but I think that this is really front of mind for a lot of us who do population health management. And I'm highlighting some amazing work of my collaborators, Mamo Yamawin, and they are an Indigenous governance body for administrative data analyses for select Northern Ontario First Nations. And I'm also highlighting some work that Dr. Janet Smiley did at Well Living House in Toronto, where they looked at urban Indigenous and found that the census undercounts urban Indigenous people in Thunder Bay and Kenora, so 2 Northwestern communities, 2 to 5 times. And so what we can do is, if we created a Northern data strategy, we might be able to address some of these differences. But sometimes it's still not good enough. And we still have to fight, the existing colonial structures and assumptions and ways of doing that our funders and governments work in. So my takeaways very quickly, 5 minutes left. Team-based work best. It's what we know. It's how we do it. Capacity building is critical for Northern rural learning health systems. We need to work with what we have, tailor our approach to the context, and then and I see that people here are innovative experts. So those are my takeaways. I have lots more interaction that I want to do, but maybe what I'll do is I'll stop sharing for now and just try to leave some space for questions. With the last 4 minutes.
Excellent. Thank you so much, Dr. Wood. It's been so great hearing your wonderful ideas. It's really inspiring. So many parallels between, the Northern Ontario and Northern BC. Like everything you're saying is really resonating. We do have lots of comments in the chat.
Yes. I am
Yeah.
okay. Thank you. Like Julie, I see your comment in the chat, and again, anyone feel free to offer questions. Is there a call to action in here about fostering cross province northern relationships? And I think that was one of my screens, and I can come back to that as well, especially if people feel here. Let me pull it up.
Yeah,
If people, oh
I think for that, yeah, for that, I really feel like there's more similarities between our two contexts than between us in Vancouver or you in Toronto, right? And so, how do we create
yeah.
those strong relationships to amplify our voice when we're working with folks who are making the rules in the South?
So then maybe what I'll do, feel free, I'll put my name in the chat. If you're on Menti, let me know. Like, and I put just rural, but know that I mean northern as well, because I'm in an urban center in northern. And I think of we the North when Toronto was in the playoffs, and here we are in Thunder Bay. You're not northern, and then everyone north of us is like, you're not northern anyway. If anyone is interested in how do we work across northern and rural learning health systems, if you want to go to Menti, and hopefully it's still active, I would love to know what you might be interested in doing. Are you interested in sort of learning more about the idea of learning health systems? Are you interested in working together on proposals? Yeah, okay, sweet. I am starting to see some responses here. Is it about identifying resourcing opportunities? So I've said open for business, but really, do you need to get more resources to do the work you want to do? Find ways to deepen or expand, strengthen my program. Awesome. Okay. Yeah, of course. The Northern folks are saying we need to respond to our local needs. Yep, absolutely. And of course, yeah, similar to me, publications are less, less important. Oh, John. Hi, John. Photo voice. Love that. I'm going to throw my email into the chat. Would love to hear from some of you if you want to follow up with me. Again, Julia has been such a great collaborator, and I'm so privileged again to know you. And John actually was with us at the workshop back in 2023. Thank you, John. And so just knowing that there is potential for us to work together in different ways. And maybe it doesn't look like a traditional research grant, but I think there's some knowledge sharing that we need to do. And so I'm just going to, I will stop sharing, but thank you all for participating. And
Thank
just
you.
thank you for listening and having me, Julia, and
Oh,
team.
thank you so much, Dr. Wood. It's been such a pleasure having you join us. And yeah, there's always space for you. It sounds like you have an affinity for BC. So, you're welcome to come anytime. We would love to have you here in person too sometime. But all the best for the rest of the afternoon, everyone. We're going to jump into our concurrent sessions that are starting in about a minute. So feel free to make your way over there. And then there's a panel session and closing at the end of the day as well. But thank you, everyone. And thank you, Dr. Wood.
Thank you, Julia. Thank you, everyone. Enjoy the rest of your day. Bye.